So welcome to today's MESED Learning Community PMP webinar. Today we're going to be hearing from Jesse Higgins on trauma-informed deprescribing, how to align patients while prescribing responsibly. My name is Casey Kader with CCSME. I also have my colleague KCC with CCSME, and we'll be supporting today's webinar. So again, just a few quick notes before we begin. Firstly, neither the presenter nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of ACCME through the joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this PMP webinar series are their own and do not represent a position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We will have a few minutes at the end of the presentation for questions and answers, so please hold any questions until that time or place them in the Q&A feature, which you'll see at the bottom of your screen in Zoom. Additionally, any slides and materials from today's webinar we'll be sending out to you in a follow-up email after the webinar is over. And finally, I'd like to introduce you all to our speaker for today. So today we have with us Jesse Higgins, who is the Director of Integrated Behavioral Health at Northern Light Acadia Hospital in Bangor. An Acadia provider since 2010, Jesse has practiced consultative psychiatry and a family medicine practice at Eastern Maine Medical Center since 2011. She developed and directs an integrated program that leverages licensed clinical social workers and psychiatric mental health nurse practitioners on site and via telehealth in outpatient medical practices throughout the state of Maine. The mission of this program is to improve access to behavioral health expertise for outpatient medical practice patients, families, providers, and staff. Jesse is also proud to co-chair the Bangor Area Clinical Substance Use Work Group, which is a clinical consortium that takes a collective public health approach to caring for patients and families impacted by substance use disorders. And additionally, she serves on the board of trustees at Partners for Peace, the Domestic Violence Resource Center for Penobscot and Piscataquis counties. And with that, I will hand it off to Jesse for today's presentation. Thank you again so much for being here with us today.
Thank you, everyone. Can you hear me okay?
So
thank you. I am going to, let me share my slides and make sure that goes well. And then I will tell you a little bit about where I am coming from with this. Okay, so yes, I do see patients. So I am the director of a program and I do oversee a program across the state of Maine for Northern Light Health. My clinical experience is that I practiced years and years ago at Acadia Hospital in Bangor in outpatient psychiatry, but for the past 15 years, I've seen patients in integrated primary care practices, including an internal medicine and family medicine practice. And I regularly rotate as a psychiatric consult provider in emergency rooms across, I think it's now 19 emergency rooms across the state of Maine. So I primarily care for patients in integrated medical settings. Let me move to the next slide. So what we're going to talk about today is compassionate deprescribing. And just to explain that term, that doesn't necessarily mean taking people off or tapering medications. It means that we're seeing that there's some sort of concern that we have about the controlled substance prescriptions a patient is on, that it is not serving them clinically, or there's some safety element that we are concerned about. And so this is really about how to align with patients while maintaining responsible prescribing practices. And this training was developed in partnership with the Maine Substance Use Disorder Learning Community. So again, the goal is the controlled substances we'll talk about are opioids, benzodiazepines, short-acting stimulants. We'll be thinking about evidence of risk, misuse, or diversion. But I'm not a big algorithm person. Algorithms definitely have their place. In best case scenario, they apply to 75 to 80% of the population. There are always outliers on either end. I think everyone likes to think that they are the outlier, which is the problem. But algorithms definitely are helpful with clinical best practice and what the evidence tells us, and are reassuring when we are moving through a schedule. But it just always is important to keep in mind the unique human being sitting in front of us and our relationship with them and the many factors that may affect their health. We are going to talk about applying trauma-informed care principles and shared values. One of the things that we know is that often in all sorts of outpatient settings, but certainly in primary care providers, in my experience, are very caring community providers. They often care for generations of families. Having really challenging conversations with patients that the patients don't understand and aren't aligned with can be really hard to do. We sometimes see controlled substances being renewed through practices for months, sometimes years, without the patient even being seen. And often when we look at those prescriptions, there are some concerns the provider has, and it's just so difficult to have those conversations. So this is really intended to give you some tools so that those conversations go well. And then we'll talk about some individualized strategies for collaborating for safer regimens. So this is about, this is a clinical necessity at times, right? The circumstances in which we'll be thinking about deprescribing or adjusting medications are when there's like a not reassuring prescription monitoring program. There's like multiple refills in a short period of time, or there's evidence of diversion, which is often the scariest and most upsetting thing for a prescriber. And this is when we feel so this is why I think the algorithms aren't always the most helpful, because it's often just something we know, right? We know this isn't working. You see the patient on your schedule, and if you're uncomfortable with it, it's not because you don't like them or they're a difficult person. It's because you know what you're about to prescribe or may have been prescribing in the past, or somebody else has been prescribing and it's new to you, is really doesn't feel like it's the right fit for this person. It feels like it might be unsafe either for them or for the community. So we're really talking about understanding that deprescribing can be an intentional disruption of something that might seem on the surface to be going relatively smoothly, but what has been prescribed historically is not part of healing for that individual. And this is especially important to be careful about our approach, because many of these people are navigating trauma, mental illness, or belong to a marginalized population, and they are more susceptible to the inherent power differential in these conversations. So we really want to equalize as much as we can. Abrupt or rigid tapering early in the when the opioid laws came into being, and we started more routinely checking PMPs and doing pill counts and all of the monitoring. And it was found that sometimes providers had been caring for patients for decades and been prescribing medication to help assuage their pain, and found that there had been diversions, there had been misuse. It really felt like a violation of the relationship. This is part of the human part of this, right? Certainly we need to think about the patient's humanity, but it's really about shared humanity. If we are doing our job and we are connecting with this person like an authentic human being, like we are and they are, and we're respectful, then we're going to have feelings and emotions when we find that somebody that has been lying to us, right? Or has been doing something we consider dangerous. The important thing is to recognize that in ourselves and work with our colleagues, with our supervisors, to get the supervision and support we need so it doesn't unfairly impact the care that we're providing. And compassionate deprescribing centers this relationship, rebuilding trust and the autonomy. So we're not talking about compliance, we're talking about collaboration. Gentle reminder that many people who are on controlled substances have a significant trauma history, disproportionately so. There's a lot of reasons for this. I know a lot of you are familiar with the ACEs. Maybe all of you study where we know that the more adverse childhood events somebody has lived through, the more likely they are to experience chronic pain. all sorts of symptoms, certainly post-traumatic stress disorder, all sorts of chronic physical health conditions they are at higher risk of struggling with. So the fact that they have a significant trauma history or a co-occurring mental illness doesn't mean that their pain isn't real or that they wouldn't benefit from treatment for pain. It means that it may be more complicated and we may be treating things we didn't realize we were treating. This is another thing when rapid tapers happen or even slower tapers, if we're not mindful of the patient's history and maybe co-occurring things that may be happening for them, we certainly have an idea of what we've been treating. For example, if it's an opioid and it's for back pain that somebody sustained in an accident or residual pain from some sort of medical procedure, that pain is for a reason. We have a clinical appropriate reason to be prescribing it, but we may also unintentionally be treating their symptoms of trauma, be treating their anxiety, be treating other things so that symptoms of mental illness may sort of surface, which might surprise not only the provider, but also the patient. So it's important to expect that to happen, to be aware of it, and to anticipate it. Also, just generally, right, people are socialized to medicate discomfort, right? You get up in the morning, you drink a cup of coffee because you're tired. You have another in the afternoon because you want to take a nap. But the society that we live in doesn't make it easy to take a nap in the afternoon. So you've got to do something. You can't sleep at night, so you take a Benadryl or something else. Most of us who have lived to the age of 40 thereafter wake up in the morning with something not feeling comfortable. And, you ask yourself, do I take an Advil or a Tylenol? There's a long-term cost for that. Most of us in the medical profession know, right? But we sort of, from the time kids are little, most of us are socialized that if your body is uncomfortable, you take a medication for it. So understanding and explaining to people that the goal is not no pain or no anxiety or no issues with focus or inattention. Those are not realistic goals for human beings. Part of being a human being is that we all struggle with all of those things to some extent. It's about how much it's impacting your functioning. So we've talked about this, but just being mindful not only of potential co-occurring mental illness, but also social determinants issues. One of the things I know happens sometimes with pill count policies is that there's like this, you have to come in the same day if you're called for a pill count. Well, in a rural state like Maine, where people struggle financially, often have lack of access to transportation, may not be able to get daycare, maybe working hourly jobs, and they're going to lose a whole day of pay if they do that. We just really have to be mindful of what is reasonable to ask of people, what the risks and benefits are for them when we have policies that may not take into consideration some of the very real barriers people experience. So just being mindful of all of that is really important. We also need to just remember that polypharmacy, lots of people have long lists of medications. And often, one of the things that I talk to people about often who are coming in talking about ADHD symptoms of focus and inattention and looking for a stimulant is there's so many people using heavy doses of cannabis now that inattention, lack of focus, low motivation, those are side effects from that substance. So no moral judgment from me for doing that, but also I can't in good conscience prescribe a medication that has high risk of, potential side effects to somebody who's experiencing side effects of another thing that they're taking into their system. So also important to look at their medication list. What are they being prescribed? Are there a lot of sedating or activating things that may be causing these symptoms? Marginalized populations, there's a lot of, we certainly need to be mindful of the power differential experienced throughout society by populations like Black, Indigenous, LGBTQ plus patients that have sort of created this lack of trust in medical institutions. I would say women also often have medical, like physical symptoms misattributed to mental illness or to anxiety. It's pretty common to hear that, and it's real. So we really do need to be mindful of that screening for co-occurring mental illness, substance use disorders, and social determinants should be universal, not only because our implicit bias might make us think that a member of one of these marginalized populations might be more susceptible to a certain kind of behavior or a certain level of concern, but because what we know from research is that people we identify with who might be the same race as us, the same gender, a similar age, similar level of education, might make us less likely to consider that they may be struggling with a substance use disorder or symptoms of mental illness. And that is not borne out by research. There is no kind of master's degree that protects you from having a substance use disorder or a mental illness. In fact, we know that many people, for example, in the medical field, are actually at higher risk of these things than the general population. So universal screening really helps us to at least mitigate our implicit bias. The clinical and social realities of overuse and diversion. Diversion is very difficult for us as prescribers. I know that I personally always worry that a substance that I prescribe might end up at some middle school party and some kid will take it and it'll just start this whole cascade of terrible things happening. What we do want to consider also, though, is that if you find that a patient has been diverting a medication, it does mean that they have been lying to you. It does mean that you cannot safely continue prescribing the medication that they have been diverting. But it also means that we need to consider, is this a person, like many people in the state of Maine right now, who has had may have lower access or removed access to benefits like housing, food costs, food benefits at a time when groceries and housing are higher than ever? Are they trying to take care of their family? That doesn't mean we want to contribute to that. It doesn't make it okay, but it is a reason, and it's something to consider that real people do. So it sort of helps us kind of reframe the behavior in a way that retains the humanity of the person in front of us. Another thing to remember is that something historically that has happened is a lot of practices would just kick the patient out of the practice. Like, you can't come back here then, you've been lying to us, you've been selling medications. Well, where are they going? Like, they don't disappear when that happens. They're going to our own communities. And they also may have families that are depending on them. They likely have chronic medical illness like diabetes, like asthma, like who's going to take care of them now? So I think this is just a reason to have these conversations, even when it's difficult, in a compassionate way that balances safety and empathy. So I think we've kind of made our case for why do this, but why compassionate, person-centered deprescribing? Really this emphasis on gradual, negotiated change, that you're working together. It reduces dropout of treatment. It builds a therapeutic alliance. I can tell you, as a person who has had many of these conversations, that our relationship is often stronger once we have worked through the initial challenge of having these conversations. Because of the way I approach the conversations, I've certainly had people get angry and walk out of the visit, but usually I would say 19 times out of 20, at some point they come back, because I have said to them, you know what, we cannot safely continue this medication at the dose that it is, or for the condition you have, or due to this circumstance or this circumstance. So we need to talk about transitioning. Your anxiety is real. I believe your anxiety. You need help and treatment, and I will walk with you through this whole process. We can walk through it together until we find something that helps you. And if they get angry and leave, they'll usually come back because somebody really saw them and held space for them, knew the truth, knew this truth that they've been ashamed of and hiding, and still wanted to help them and take care of them and be present with them. And that's a huge intervention in and of itself. This honors their lived experience and avoids re-traumatizing people who have already been through plenty of trauma. And it supports these sustainable, values-driven transitions. I can tell you, I've seen some people for over a decade who we started when they came to me with very unsafe medication regimens that we gradually transitioned off of, and they're doing well, and they're still coming. And particularly, I will say, in my experience as somebody who is a psychiatric provider, this is more applicable to things like benzodiazepines for me. And people like find their selves and their emotions and their feelings, and it's a remarkable transition, but it takes a long time to do safely. So here are just the tools. Like, one of the things when I go to any kind of a training, what I really want is to walk out with something I can actually do, something actionable that makes sense to me, and also a way that I can kind of make the case for doing it in my organization. And so I want to offer you some practical tools, paper schedules, and PDMP use. I'm going to go through pretty quickly because those are things that there's a lot of information out there about these things, other webinars about them. I really want to focus on the shared decision-making frameworks, but I'll also talk a bit about ADHD stimulant optimization checklist, because it just, which sounds fancy, but it's just really things to consider with stimulants. Like, there's a bananas amount of stimulant prescribing going on out there. So just things to think about. For taper schedules, again, there's no algorithm that applies to everybody. It's important to be mindful of algorithms and to kind of research them. If a patient is eligible for a slow dose reduction, for example, if they are a person who is at an unsafe, I've had patients refer to me on 6 milligrams a day of clonazepam or 8 milligrams a day who came in slurring their words that I had to arrange for them to get a ride home because I didn't feel like they were safe to drive. But we very, very, very slowly and gradually transitioned from those medications, because it was not their fault that they had been prescribed that high a dosage, and also the risk of causing more problems for them than I was solving by going too quickly was very high. In the case of diversion, or when there's a urine drug screen and a diversion issue that are, sort of inconsistent with the way that you've been prescribing, that may not be an option, right? So be realistic with people. Also, introduce medication-assisted treatment to everyone who is eligible for it, and recovery options early. Peer support early. Even if they're not interested at all, that's okay. It's still important to educate people about what's available. If you're talking about high-dose opioid deprescribing, you really want to have those conversations with people so they know what the options are. If it's something ideally you can offer in your practice, that is the best case scenario for many people, because it is destigmatizes needing that kind of treatment, and it helps people. Also, they may not be interested in the beginning, but they may struggle through a taper schedule. And if that's the case, we can always bring it up again in a non-judgmental way. Anticipate that there will be, depending on what substance you're working with, that there may be symptoms of withdrawal prescribed to those. Even if they don't experience a particular symptom, then it will not hurt to have one of these medications like clonidine in their household to help address any symptoms that they might experience. It's only a small amount is needed typically for withdrawal, and you're going to want to be seeing them more frequently if that's something that you're going to be working with. But you don't want to wait until they try and get a hold of you at 2 a.m. because they are struggling with withdrawal symptoms. Tracking tools can be very simple. There's a lot of apps for your phone where people can track their mood, their pain, their functioning. You can kind of research those, look together, see what works. There's a lot of free ones out there. Or I have lots of people who keep a little notebook and just kind of keep track of what's going on with them. It can be really helpful. Just make sure if you ask somebody to do one of those things that you ask them what the results were next time, because you want to make sure that you're not just asking people to do that for no reason, and it helps them know that you really see them and remember who they are and are invested. Medication adjustment versus stopping is a big difference. You're not stopping their medication, not saying we're not going to treat you with anything, we don't care anymore about you, which is really the huge fear that people have. We're saying we're going to adjust your medication, we're going to transition your medication, because that's the reality of what's happening. We want to use correct language around that. That's not going to scare people for no reason. The PMP, I know you all know what it is. I will, my plug for this is that many of our organizations, for those of us who work in health systems, have policies that may say you need to check it every 90 days, or you only need to check it every so many prescriptions, or you don't need to check it for stimulants. I check it every time for every controlled substance. It doesn't hurt anybody. It takes like 2 seconds, and it just helps me follow a pattern over time for somebody. So I just know what's going on. It doesn't mean that it's actionable. Most of the time it's not, but it helps us maintain an open, transparent relationship and prevents me from doing something that might contribute in a negative way to them or to the community. And when there is a flag in the PMP, we'll talk about this communication when we're having these challenging conversations, but have the conversation. Let people know when you have a concern, let them know what it is. They will know that there's something wrong when you're talking to them. When we have some sort of a thought or feeling or suspicion, it's really apparent to people. They are looking for authenticity and they can see it a mile away. So just say it out loud, have the conversation with them. That actually builds trust over time, even if it's a hard initial conversation. As far as ADHD goes, one of the things I'll say is that lots of people come in with symptoms of ADHD. Anyone on this call who has TikTok or any short form videos, it's not any one by name, but they all have mention ADHD, mention autism, lots of mental health, like whatever's trending at the moment. I'm seeing lots of trauma bond things now. So people are coming in talking about those. It's not to say they're not real. It's not to say that ADHD isn't underdiagnosed in adults. But we're always looking for something that sort of explains our human suffering. And there's a wide range of struggling with focus and inattention. As I said, that is in the normal human. I mean, you will talk to people and they'll say, well, I'm in graduate school and I work full time and I have 3 kids and I'm married and I have a book club and I can't read the whole book all the way through. And they're like, right, like, wow, that's a lot of things. So just be mindful of, first of all, if they're looking to be superhuman and have unrealistic expectations for themselves, in which case some sort of counseling or supportive therapy might be helpful. For trauma looks a lot like PTSD, can look a lot like ADHD. There is difficulty with focus and attention often, with motivation often. So sometimes when people are misdiagnosed with ADHD and you prescribe a stimulant, they will become more anxious. But some people with PTSD, especially survivors of sexual trauma, will experience it as a relief because it helps them with be hypervigilant and feel super aware of their surroundings, which makes them feel safer. So we want to be mindful of that as well. Long-acting formulations are better than shorter-acting formulations for a lot of reasons. They keep people from going up and down throughout the day. They're also less likely to be diverted or misused. We're doing all the usual checks on diversion. Clear guidance, I will say breakfast. I had a recent eye-opening conversation a few months ago and have changed my scripting around breakfast with people once I realized that well-balanced breakfast is not universal language to people. So people will often report that they need a short-acting stimulant in the afternoon because their medication wears off in the morning. If you take it without eating something solid first, it will work too fast. Often people have more side effects, more anxiety and jitteriness, but it also will wear off more quickly. You are meant to eat a meal before you take a stimulant. And so I explain to people what that means. It means ideally like a whole grain, some sort of protein, ideally a fruit of some sort. So like even a bowl of cereal and milk, or a piece of toast and peanut butter and, some apple slices, or, whatever's easy for you, even a smoothie, but only if it's like a protein, good smoothie with some solid stuff in it. That will help a lot and prevent, I think, a lot of this kind of need for late afternoon short acting stimulants. Safe storage and instructions really for all controlled substances, keep them locked. I will say sharing happens all the time. For many of you, I will say I certainly hear stories all the time of patients coming to me saying, I know Ritalin works for me because I took some from my mother, my brother, my best friend at a party. What that means is that people are freely sharing stimulants all across the community that we are prescribing. So when we are prescribing stimulants, it's important to have an initial conversation and an ongoing conversation about the dangers of sharing. If the wrong person takes this medication, this is working for you. If you share it with somebody with an unknown underlying cardiac event, you risk they could die of sudden cardiac death when they take this medication. If you prescribe it to somebody who doesn't even know they have a history in their family of a bipolar disorder, they could become psychotic and it could destabilize their entire life. This isn't a safe thing to share with your friends. And I think it's really important that we let people know that they need to be evaluated. If they think they need this medication, they should see a provider and be evaluated to see if they are a good candidate for it. The framework I want to share here is around trauma-informed care principles. I talk about everything in terms of trauma-informed care. Not everybody has a significant trauma history, although post-COVID, I would say most people do. But worst case scenario, this is just like kindness, right? And good care and shared humanity. So safety and this scripting is not meant for anyone to memorize. Certainly, I have definitely found that some people find it helpful to have scripting. And then over time, when you practice, you sort of develop your own voice to have these conversations. But safety means we are prescribing options and respecting readiness. The first time I have a conversation like this, or often the first time I meet a patient, I will say, we're here and this is your treatment space and I am a guest in your space. This is about your body, your healthcare and your life, and you're an expert at yourself. I'm here because I have some clinical expertise, so we need each other to be successful. I'm going to need you to be honest with me. If I make a recommendation and you think that is a terrible recommendation, I'm not doing that, then please tell me. It won't hurt my feelings. And I often will say, it's really hard to hurt my feelings. I just want you to share what's going on for you. Makes no sense for you to tell me what you think I want to hear. This is not for me. And what that does, and I will tell you honestly, when you say that sort of thing to folks who are in a marginalized group, they will cry or get very emotional because they're not used to healthcare providers talking to them in a way that respects their autonomy and their expertise on themselves. It's very, very important to establish that standard, I think, really early. It also frames for us every time. It's a reminder to me, I am a guest in this space and I am here to help. Trustworthiness and transparency, that means that we are explaining the why. We're not just telling people what the orders are. We are explaining why we're thinking what we're thinking. And we're offering options wherever those options are possible. Certainly, if a very slow taper is not an option for this particular person because of the circumstances, we don't want to present that as an option. If medication-assisted treatment and recovery supports are the only option we can safely provide, we want to be clear what the options are within those categories. There still are choices that people can make. Peer support, just normalize that most humans on Earth use peer support, right? Whether sometimes in recovery, it's a peer recovery specialist, a therapist, a support group in the community, might be a Facebook group online, right? A lot of people or on different kinds of social media find different groups that they align with and find supportive. So a lot of people find it helpful to talk to other people who have been through this. Collaboration and mutuality, again, we want to center the patient as equal in their decision making. We are here together to have this conversation. Now, at the end of the day, are we going to prescribe what they want if we don't think it's safe? No. But are they going to take something that we want them to take if they don't want to? Also no. So we are equal. We need to agree for this to work. Empowerment and voice and choice. Acknowledge that this person has been through a lot. Whatever it is they're dealing with now, they are either a person who's been dealing with chronic pain, with struggling with their focus and inattention and distraction and difficulty being motivated, or they've been struggling with crippling anxiety. These things are all real and they are still here. They're coming to appointments. That is something to celebrate. And then always acknowledging that there are certain members of our population that are disproportionately more likely to have experienced trauma in healthcare are disproportionately more likely to be struggling with some of these things and have a history of not being heard by anybody in authority. And it is really important that our approach takes that into account. Also, if somebody is a member of a certain religious tradition or tribe or whatever their affiliation might be, and we don't represent that affiliation, or really either way, we want to make sure that we offer them to at least research with them what their options are and include other voices and kinds of support. Shared decision frameworks. We'll talk about motivational interviewing in detail in just a minute, but we're really talking about change management because we're letting them know a change is going to happen. So how can we do this as supportively as possible, where we are partnering with them and not just telling them what's happening. So asking people how these symptoms are affecting their life, and really like not just symptoms of that we're treating with the medication, but side effects of the medication, right? If we're seeing that somebody looks jittery or looks tired, or they're on a dose of a benzodiazepine and they're still reporting that they have panic attacks and anxiety attacks all the time and the medication isn't helping them, or they're on a high dose of an opioid and they're still reporting that they're not able to mobilize, they can't function, it's not helping with their pain. Well, then let's talk about that. Like, what could be different? What might happen if we adjust these medications? Might we find something that works better for you? Always anything that's on, it is helpful for accountability, I think, for both the provider and the patient to sign some sort of agreement when you're doing a controlled substance, or either deprescribing or prescribing controlled substances, whatever the plan is, so that both of your responsibilities are represented there, and we can kind of review over time and hold each other to account. But that's not just a mandate for the patient to sign. That's both of us saying that we're gonna be in this together, and then make sure that we are offering follow-up support. And whenever possible, if somebody is struggling with withdrawal symptoms, if you can pause for a period of time, I've done that many times before we're ready to continue. That makes sense for a lot of people. ORS, for those of you who haven't had the new motivational interviewing edition, it just came out last year and it is great. There's a lot of tools in there. More language, that was the other one that's kind of antiquated now, we don't really use anymore. And also, ORS is just a really cool way of, to me, I'm say cool in like the nerdiest way ever, but of framing conversations with people. It helps us have a framework. So it just stands for open-ended questions, because we're not, if you ask yes or no questions, you're not going to learn a lot. And it also, often those questions are trying to lead people to where we want them to go, approaching with curiosity about their experience provides a lot more information, offering affirmations, and we'll look at what that exactly can look like. Just reflecting that they're likely ambivalent about this change, and how can we find whatever motivation they have and build on that. And summarize the shared understanding to make sure that we are on the same page at the end of each visit. So here are some examples of open-ended questions. So tell me more about how you feel when you take this medication. That helps us learn about what it's doing for them, and often it's more than we thought it was doing. They may notice that they feel more relaxed, or they feel more anxious, or all sorts of things that we weren't even associating with what we were prescribing. That's important to know, and it will help us understand what would be an effective transition, what that might look like. Affirmation is, again, just honoring all that they've been through thus far. They are coming to appointments, so they are committed to managing their health. So that's something to celebrate. That's not easy to do for most people. Reflections is really just reflecting back what you're hearing. There was, in the old version of motivational interviewing, there was a lot of like, it sounds like you feel this way. And people do not like that now. They recognize that as kind of therapist speak. I think it kind of rings hollow, whatever comes after that. Helpful for you. You can imagine that coming first. But really, it's like, it's funny because I have a 14-year-old daughter now, and I think about this the same way. When she ends a paper, an essay, she'll always say, in conclusion. And I'm like, it's okay to put that, but then take it out because you don't want to put in conclusion every time. But it can be helpful as a framework and a placeholder. And maybe that's true of it sounds like too. So you're feeling nervous about tapering, but also curious to help you feel more in control. Whatever it is you're hearing, listen for the opportunity to align. And certainly validate back to them their fears, but also if you hear any opportunity for alignment with this plan, make sure you say that too. And then the summary should really just include what you're hearing, what you've said, so that I like this here. So far, we've talked about your concerns about sleep and your hope to reduce side effects. Let's consider a plan that honors both. And then here we'll look at, actually, I think there is, yeah. So in terms of a case discussion, I just will bring this person up. This is not a real person. Don't worry. This is just a made up person, but it's a fair example of what this can look like. So you're meeting with a long-term patient of yours that you've been seeing for a long time. They're prescribed oxycodone for low back pain from a car accident sustained years ago. They have post-traumatic stress disorder, so also symptoms of trauma, maybe on other medications for that. And their recent urine drug screen unexpectedly showed methamphetamine. Unexpected methamphetamine is happening a lot more, at least in my practice, than it used to. And so you might want to begin a non-judgmental conversation based on safety and trust, and possibly initiate a deprescribing plan. So there is a knee-jerk reaction when we see methamphetamine in somebody's urine drug screen where we think, oh my God, what if they're diverting their medication? They might be selling it. They're involved in this community where there's drug dealing. Take a breath. One of the primary care providers I've worked with for years and years said one day to me years ago, when we were doing a lot of the opioid tapers several years ago, said, you said something once that really stuck with me and has really changed my practice. And I said, wow, what was it? And I was thinking about all this stuff, like the motivational interviewing, the scripting. And he said, take a deep breath. And I was like, take a deep breath. And he said, yeah, I realized that when I go into an appointment and I know I'm going to need to transition medication, a controlled substance, and the patient knows that's going to happen, they are agitated and anxious, and I am agitated and anxious. And when we come into a space together, there's no therapeutic conversation happening there because we are both defensive, agitated, and anxious. He said, when I stop outside the door and I take like 5-6 seconds to take a slow, deep breath and then walk in, it's a very different conversation. And I think, things like that, whatever works for you to help you, I think that's a really good exercise to remind yourself of what you're doing when you go into those appointments can be really helpful and prevent us from that kind of reactive conversation. So here are just some examples of how you could use ORs in that situation. Hey, can you walk me through what's been going on lately, especially with your pain and how you're coping day to day? You've been living with a lot. You've got physical pain, trauma, all the daily stress that comes with all of that. You keep showing up and trying to stay on track. And that says a lot about your resilience and who you are. We've been working together a long time. You're trying to get through every day with the tools that you have. At the same time, there's a part of you that's worried about what happens if we make changes to these medications. You've been really struggling with pain and nightmares. The urine screen shows something unexpected, and I want to talk with you about it in a way that keeps you safe and supported. We are in this together. You can see how that would land. That can be a therapeutic conversation. I mean, I have said to a patient who had all sorts of like super tons of substances in their urine drug screen unexpectedly and had come to me on a controlled substances. I was like, look, here we are. We're on the same page now. You can finally like lower your shoulders, take a deep breath. Let's work through this together. We're going to work together through this. You don't have to pretend. You were at a crossroads. You could choose to do that. You could choose to continue to pretend And I will say, okay, and there's only so much I can do with that. I can't be that helpful. But if we want to start talking about what might be different, if you decide to do something different right now, I'm here for that. And if you can't do that today and you want to come back and do that later, I'm here then too. And I think that can be a really powerful intervention. So these are the tapering principles, just to summarize, maybe thinking about readiness, anticipating what might happen, how we can provide whatever kind of support, whether that's medication or therapy or peer support, thinking about who this individual is and what might help them, plan for managing their symptoms, slowly making these cross titrations or whatever this looks like whenever possible, and maintaining non-judgmental language. Remembering all of us, I know, have core, values that we really identify with. It happens to be like years and years ago at Northern Light Health. I looked up sort of what the institutional values are, as sort of a leader of a healthcare team, to think about how we could frame some things. And we really frame everything in terms of that now because they really resonate with me. And we did a lot of exercises to think about what this means to us, not as like workers, but as human beings. Compassion, accountability, integrity, and respect, and really defining what those mean. And then I always add shared humanity because I think in healthcare that is really critical to everything we do. Healing is not about strategy or algorithms or statistics. Healing is about the relationship between you and the unique human being sitting in front of you. Someone said to me a long time ago that by virtue of working in healthcare, all of us are community activists. And you can choose to use that power or you can choose not to, but you are by default a community activist. And to me, this is activism in the best possible sense. So thank you all, and I would be happy to answer any questions that might be helpful.
So we do have, we had a question that came through in the chat from Cassandra, who said she thinks you answered her question, but I'd love to just summarize her question because it was a really good one, and I think probably other people are wondering as well. And it's kind of just about any strategies speaking to patients to kind of make them feel better about the larger time investment that tapering might be. For example, a therapeutic approach like CBT, which would be much more of an investment of time. So anything you have like in the toolkit that might speak to that.
Yeah, I think that is a really good question. I think one of the ways that I talk about that is that I will never push you to do something that you're not ready for or not comfortable with or not able to do, but we're going to do everything we can to make that possible. And it is true that sometimes when we're moving to something that's really going to have more of a lasting impact on how your life is and who you are as a person, that it can take more of an investment of your time and energy. Most things do that are worthwhile. So it's really difficult for any of us to do this alone. We really need some support and help. So I would offer them whatever options. There's a lot of telehealth options for people who have difficulty with transportation. We always want to be mindful of people's ability to pay, of childcare issues and things like that. So really figuring out what resources might be available to them that might be realistic. A lot of people will say, yeah, I'd love to see an in-person therapist, but I just don't have time to do that. And we can sometimes, we can often I see a lot of patients by telehealth during their lunch break. So there are ways that we can make it work for people, but really, yeah, I think being curious about what that hesitation is about, what barriers they anticipate, and then we can kind of be creative with them about how we can address them.
Thank you so much. We have another question from Dr. Mock, who first says that you knocked it out of the park, of course, and is wondering, for those prescribers who struggle, maybe fear bringing up the subject of deprescribing, what do you find is the most helpful way for them to start? Maybe a role play with a peer, etc.
Yeah, that's a really good idea. I think role play with a peer is great. There is there's some scripting available. I think if you look through, like truly the OARS framework, I actually find really helpful for people in terms of explaining how to, because the problem, right, with scripting is that it's not individualized to the unique human being, but the framework can be. So if you look at the framework and the scripting and then you present that to a peer, you could practice it together. Um, and just sort of go through and see the workflow. Honestly, you're probably going to have some difficult conversations before you find your voice. It takes a while to practice it. It took me a while, and it was pretty scary in the beginning when I first started doing it. Um, I will say I've heard a lot of people, and many of you probably have too, and I have to say like, oh yeah, I know, like if you look at their med list, it's awful, but I inherited them. And that is a lot of how we kind of justify continuing something that we feel is unsafe. Certainly, I'm not advocating for destabilizing a patient who is stable on their current medications, or just like because we have a rule, like a no benzodiazepine rule, that we're going to transition everybody off. I don't like that kind of rigidity. I don't think that's helpful for people. But if you're prescribing something that feels unsafe to you, if you think there's a problem, you're not contributing to the well-being of that person or impairing their safety or the safety of the community, there's really not a justification for avoiding a challenging conversation. I do know that CCSME, that through the state, has resources that they will help you if you're struggling, if your organization needs some training or support. There are a lot of resources in the state of Maine available to people. So if this seems to be something that you really want help with and want to grow your skill set, then that there we know, like we've all been there, right? Like it's nobody is like naturally awesome at this. It's hard work and it's a muscle. It's a new skill. So it makes sense that you would need help. Everyone needs help.
Absolutely. And I'll direct people, there's a link in the chat there to our technical assistance request form. So that's where you can get some of that assistance that Jesse mentioned. I don't see any other questions in the chat at this time. But Jesse, I always like to ask if there was anything you didn't get to that you wanted to talk about, or any question that you wish had been asked.
I don't think, I guess the way that I think about this is that it's kind of a crapshoot which end of the table you're at in the exam room, right? You could be the patient. We are all patients, and we are all, we all work in the medical field. So there is no us and them. We are all them. So really making sure that we're working with each human being the way we would want someone to care for us. And in particular, sometimes there are people that it's hard for us to think that way because it's hard to identify with them. But usually we have someone in our life that we care about that probably when they go into a healthcare setting is not the most charming person on earth. And we still want them to receive empathetic, excellent care. Everyone deserves empathetic, excellent care. And I think that we can get there. People feel it when we care about them. There's nothing, if you think about your own healthcare encounters, the times for me that I have felt like walked out and I'm like, wow, that was amazing, is when somebody will stop and turn around to me, look at me, and I know that they care about me. I know that they are thinking about who I am as a person and what I'm dealing with, and they want to help me. And that is an intervention that there is no medication that is better than. So I think that's the way to think about that. And that also gives us back, right? Like we have these EHRs and all of these algorithms and reporting tools and screening tools and stuff, but that is the part that we got into this for. That was our calling. That's what makes this career resonate with us. That's what makes us go home at the end of the day and feel good about what we're doing. And I think for that reason, if no other reason, for that reason, it's worth doing.
Absolutely. And we did get one more question in from Dr. Mott. Some patients are very firm in their belief that their autonomy includes continuing high dose opioids. And if you have any thoughts on some good open-ended questions for patients who might fall into that category.
Yeah, I think just curiosity. What is this medication? How is this medication helping you? What are you worried about happening if it doesn't? Have you ever been had this medication decreased? And if so, what was that like? And that helps us kind of discuss what a transition might look like. That this isn't remembering to not say medication stopping or even tapering a lot of the time, but transitioning or adjusting medication. Because often there's a different kind of medication or non-medication support that will be more effective than what they're currently doing. So and then kind of once we do all of these things and that first appointment, we may not start the taper. I would say if you don't have to, don't do it at that first appointment, but you are going to have to set a time frame if somebody really doesn't want to do it and you're really concerned about their safety, and then you're going to have to stick with that. But I would just be very clear that you see and understand their concerns, their their pain is real. You are not questioning their pain, and that it's just more complex than you may have realized. And you might need to invite more people in with you and the patient to help them receive the kind of care and recovery that you want for them.
Thank you. All right. Oh, one more question just came in. Do you ever ask what the patient's conversations were like with a previous provider, knowing it can be difficult to comment on a fellow provider's style or treatment approach?
Usually not. I would say usually not because I don't know what the benefit of that would be. Like, I mean, I am a human being. So sometimes I see medication regimens when people are referred to me and I think, oh my goodness, like how did this happen? But I never would say that to a patient, and people will be very defensive of their previous provider too, if they have been on a high dose of a controlled substance, or a dangerous combination, or, and say, this person, and I say, we have different information now about the safety of these medications. And really clinically, we've talked about working together on this, and we need to be in agreement. And I can't clinically, knowing what I know, safely continue this medication at this dosage. And let me tell you why. I'm worried about respiratory depression. I'm worried about whatever the circumstances are. Here's what can happen when people are at this dosage of a medication. And here's what we know about the effectiveness of this. And here's what I'm seeing with you as a human being that makes me think this is not going to be the thing that helps you going forward. So I think more focused on what my approach is, my relationship with them, what's going on now, what the evidence is, but always not just the evidence, but why I think for them this makes sense, why in my clinical judgment I am prioritizing this change. And I would say another thing that I would say on the not helpful list is saying, like, well, this is the law, so this is what I have to do. Or this is what my organization they made this rule, so sorry, I wish I could do it, but I can't. That's not helpful to people. That does not make them feel seen or supported or heard. So just make sure that if you aren't familiar and comfortable with the research and evidence around why the law or the rules are the way they are, again, you can reach out to this team or familiarize yourself with some research so that you're able to articulate that and why your concerns for them are real and mean that you do care about them, not that you don't.
Great. Thank you so much. And so with that, I just want to say thank you again to Jessie for this wonderful presentation. Thank you to everyone for attending, and we hope to see you at another webinar again soon.